Hello everyone. Today we'll be talking about arrhythmogenic right ventricular dysplasia. So it is an autosomal dominant condition, and basically what happens in arrhythmogenic right ventricular cardiomyopathy is that this fatty infiltration of the right ventricular free wall. So wherever the right ventricular wall normally it should contain myocytes and all, so there is fat gets deposited in that tissue, in that myocardial tissue, and that leads to fatty infiltration. And because of this fat infiltration, it predisposes to ventricular arrhythmias, sudden cardiac death, and biventricular failure. Because what happens is that this fatty infiltration can be fatty infiltration can be a site for induction of arrhythmias, as well as can lead to sudden cardiac death and biventricular failure. So as you can see here, this is a normal right ventricle with a myocardium and all, and you can hear that there is fatty replacement of this heart muscle. So fat has replaced this heart muscle here. It is the second most common cause of sudden cardiac death in young people after HOCM. So hypertrophic obstructive cardiomyopathy is the most common cause, followed by which there is the second cause is this arrhythmogenic right ventricular cardiomyopathy, account for second cause. The prevalence is how much is 1 in 500. So diagnosis is difficult and it relies on a combination of clinical, electrocardiographic and radiological features, which is defined by the 2010 task force criteria. So this criteria I'll give you in the last. We will not go into much detail of it because it's quite complex and all. You need to remember a lot of things in that. So the table I'll be mentioned. Whoever want to go in more detail can read this table as well. So it is seen in 1 per 2,500 to 1 per 5,000 population. This disorder accounts for what is called a 5 to 10% of sudden unexplained death in individuals less than 65 years of age. It occurs in young adults and has a male to female ratio of 2.7:1. So that means it is more common in males. So what is pathophysiology? As we already discussed, there is fatty infiltration and fibrosis of the right ventricular myocardium. This leads to progressive RV dilatation and dysfunction. The left ventricle is less commonly involved and the septum is relatively spread. The prognosis is worse if even when there is involvement of left ventricle involvement. So the mechanism for myocardial loss includes the apoptosis. The myocardial there can be loss because of apoptosis, and because of inflammation, enhanced fibrosis, there can be loss of myocardial function and fatty replacement of the myocardium. Histology, as we have said, there is replacement of cardiomyocytes by adipose and fibrous tissues. So in most cases of ARVC, it is inherited as an autosomal dominant trait caused by mutations in genes encoding for desmosomal proteins, basically plakoglobin, desmoplakin, placofilin 2, and desmoglin 2. So arrhythmogenic right ventricular dysplasia, there is a defect in the what is called as abnormality in the following proteins. It's called plakoglobin, placofilin, desmoplakin, desmoglin as well. Etiology, it is an inherited disorder as it is already present in the fetus. This in familial cases can be seen in account for 30 to 90% of case. In other cases, it may result from an acquired etiology such as viral infection, myocarditis can cause. It is also likely that patients with a genetic predisposition are more likely to develop myocarditis. EROD causes symptoms due to ventricular ectopic beats or sustained VT के वजह से होता है VT, and this typically presents with palpitations, syncope or cardiac arrest. The first presenting symptoms can be sometimes only sudden cardiac death, usually develops between the second and fourth decade of life. Over time, surviving patients develop features of right ventricular failure. ECG features comes to most commonly it is seen as T-wave inversions in the right precordial leads, that is V1 to V3, in absence of right bundle branch block. It is seen in 85% of the case, and what is the most specific finding is called the epsilon wave. And also there is localized QRS widening in V1 to V3 because there is involvement of right ventricle, and thus there is widening of the QRS here in the V1 to V3. Also the V1 to V3 is involved because these are all right precordial leads. And next is the prolonged S wave upstroke of 55 milliseconds in V1 to V3. So epsilon wave, it is a small deflection. You can see as a small deflection after the QRS wave, there is a small deflection, extra deflection you can see. It is buried at the end of QRS. This is basically caused by the post-excitation of myocytes in the right ventricle. So what happens is in right ventricle, there is a fatty deposits are there, and there is myocytes get suppressed within the fat tissues. So there is delayed excitation of this myocyte which are hidden inside within the fibrous tissue or the fatty tissue, and that late excitation of this myocytes leads to what is called as epsilon wave. So you can see here this is epsilon wave, as you can see in the lead V1 due to RV conduction delay. Epsilon waves are the most specific and characteristic finding in ARVD. In ARVD, myocytes are replaced by fat, producing islands of viable myocytes in a sea of fat. So this causes a small blip seen during the ST segment of the ECG. However, epsilon waves can also be seen in patients with posterior myocardial infarction, right ventricular infarction, infiltrative diseases, and sarcoidosis. So you can see ECG examples here. The pattern can be seen as epsilon wave here, and this is again an extra wave. You can see this is epsilon wave. This is again epsilon wave here. And as already said, there is a prolonged S wave, prolonged S wave upstroke in V2 with a localized QRS widening. You can see here. So other important feature is ventricular ectopy. Generally, LBBB morphology ectopy can occur with rates of around more than 1,000 per 24 hours is very important. So paroxysmal episodes of ventricular tachycardia with LBB morphology called RVOT tachycardia. So ventricular arrhythmogenic arrhythmias in arrhythmogenic right ventricular cardiomyopathy. Up to 2/3 of patients have ventricular arrhythmias on resting or ambulatory ECG monitoring and exercise testing. These ventricular arrhythmias are usually of RV origin. Now coming to 2D echo and ARVD, 2D echo, what is important you have to see is one is because of this fatty infiltration and all, there is the dilatation of the right ventricular outflow tract. So right ventricular outflow tract dimensions, as you can see in the parasternal long axis view here, is showing left ventricle, the left atrium, the aorta, and the right ventricle. You can see here right ventricle looks dilated, and in parasternal, also in the parasternal short axis view at the aortic level, you can see the dilated right ventricular outflow tract of around 38 millimeters here, and in patient with this one. You can also see a patient with arrhythmogenic right ventricular cardiomyopathy and severely dilated RV outflow tract diameter measured in parasternal short axis view is 55.8 mm. So right ventricular fractional area change measured from an apical four-chamber view in a patient with arrhythmogenic RV cardiomyopathy with severe RV dilatation and pronounced aneurysm in the RV apex. Coming to cardiac MRI is an excellent tool for visualizing that. It can help in two things. First, it can visualize the right ventricle, and also it can give about the amount of involvement of the myocardium, which is replaced by fatty tissue and all. So bright signal in the RV free wall due to myocardial atrophy with fatty replacement can also be seen. Endomyocardial biopsy, transvenous biopsy of the right ventricle can be highly specific for ARVC, but it has low sensitivity. So risk assessment. So ARVD patients are, we have already said that they are high risk of getting sudden cardiac death. So any patient of ARVD with a history of syncope due to cardiac arrest, recurrent arrhythmias not supported by antiarrhythmic drugs, and a family history of cardiac arrest. So all these three are the high risk features. That is any history of syncope, recurrent arrhythmias, which is not suppressed by them, and family history of cardiac arrest in first degree relatives. Diagnostic criteria, as I've already said, there are two criteria. One is 2010 task force criteria. It's quite complex, involves 4 categories. One is the global or regional dysfunctional and structural alteration by 2D echocardiogram. There's major and minor criteria. And you also have tissue characterization by means of endomyocardial biopsy or by cardiac MRI. And you have repolarization abnormality, that is ECG related changes. And depolarization conduction abnormality, that is epsilon wave and late potentials of that you can see here. And also arrhythmias and family history is also included in that. So 6 components are involved in this criteria. That is family history or genetics, arrhythmias, depolarization, conduction abnormalities, repolarization abnormalities, tissue characterization, and global regional. So treatment option. Coming to the treatment option, what are the treatment options there? The primary treatment involves arrhythmia suppression and prevention of thrombus formation. Okay, in patient with no high risk features, with initial treatment is with antiarrhythmic drugs such as beta blockers or amiodarone to suppress the catecholaminergic and trigger the ventricular arrhythmias. Then the most effective drug for this is sotalol. Warfarin is often recommended to prevent RV thrombus in this case of this. In patient with persistent symptomatic arrhythmias, radiofrequency ablation of conduction pathway may be attempted. Patient with any high risk features requires urgent incision of ICD. That is patient with a sudden cardiac death, history of sudden cardiac death in any of the family members, or have episodes of syncope, or have refractory arrhythmias and all. In severe cases, cardiac transplantation may be required. Coming to guidelines, so as per ESC guidelines, all the patients with ARVC should avoid competitive sports. Beta blockers titrated to the maximal tolerated dose are recommended as a first-line therapy. ICD implantation is recommended in patients with history of aborted sudden cardiac death and a hemodynamically poorly tolerated VT. So hope you have liked this video. This is all about arrhythmogenic right ventricular cardiomyopathy. If you have any queries or any doubt, you can comment in my comment box. If you like my video, please share with others and do subscribe to my YouTube channel, Dr. Akif Baig. Thank you.